Good morning, Dr. Kirti.
Hello, Kirti.
Good morning, sir.
Good morning, sir. Kirti on the speaker.
Where చూసాను
Speaker ఉంది. Kirti. Hello. Video ఏం లేదు.
సార్ ఎక్కడున్నారు సార్? వీడియో లేదంటున్నారు.
తలదూపు అంటే వీడియో ఆన్ చేయలేదు. హలో కీర్తి, అమ్మాయి ఫోన్ మాట్లాడలేదు.
ఫోన్ చేయండి సార్.
యాక్చువల్గా ఆన్లో ఉంది, ఇప్పుడు మళ్ళీ లేదు. ఫోన్ చేస్తాను.
సార్ లైన్లోకి వచ్చారా సార్? డేవిడ్ సార్
ఫోన్ చేశాను సార్, ఫోన్ చేశాను.
అనర్థదాయకమైన ప్రభావాన్ని అలాగే ఒక ఇంటిలో నిర్మించేటువంటి
హలో కిట్టి
సార్
ఆంటీ ప్రెజెంటేషన్.
సార్ మిడి కవర్ దాంతో ఓపెన్ అవుతున్నాను.
అలాగే అలాగే.
గుడ్ మార్నింగ్ సార్.
సార్ గుడ్ మార్నింగ్.
సార్ గుడ్ మార్నింగ్ సార్.
గుడ్ మార్నింగ్.
గుడ్ మార్నింగ్ అమ్మా.
గుడ్ మార్నింగ్ అన్న.
స్టార్ట్ ద ప్రెజెంటేషన్ అన్న. గుడ్ మార్నింగ్.
గుడ్ మార్నింగ్ మోహన్ సార్.
Yeah,
మార్నింగ్. గుడ్ మార్నింగ్.
good morning all of you. Today Dr. Kirti is going to present the case Hemoperfusion and its role in ICU. So Dr. Mohan Maharaj sir is a moderator today. I request Dr. Mohan Maharaj sir to introduce Dr. Kirti. Sir.
ఏముంది సార్, ఓల్డ్ వైన్ న్యూ బాటిల్ అని చెప్పేసి మళ్ళీ ఇంట్రడక్షన్ ఏముంది కానీ, బట్ ఎనీవే ఇట్స్ యాక్చువల్లీ యూ ఆల్ షుడ్ బి సేమ్ కదా. మీరు, మోహన్ రావు, కీర్తి అందరూ కాకినాడే కదా. ఎనీవే She is from Kakinada, who has done MBBS from Kakinada, Rangaraya, and done PG from Siddhartha Medical College, Vijayawada. And she worked in medical college assistant professor, and she worked in care hospitals, and she has done her IDCCM with her friend support of Dr. M. Srinivas and Dr. Rani. And now presently she is working in Medicover with his enthusiasm to do her EM critical care for the future. I wish her all the best futures, and I request Dr. Kirti to start the class. Thank you.
Good morning. Today I am going to discuss about hemoperfusion and its role in ICU. Coming to the case scenarios.
Slide show lo పెట్టమ్మా అది.
Yes, sir. Sure.
రావట్లేదా?
Yes, sir.
అలాగే స్లైడ్ షో సింబల్ ఉంది కదా, దాని మీద క్లిక్ చేయ. దాని మీద ఇది కాదు, స్లైడ్ షో సింబల్ వస్తుంది కదా,
ఇదా సార్?
డార్క్ దీంట్లో అది. Okay.
Coming to the case scenarios, a 25-year-old farmer with no comorbidities with alleged substance intake. On presentation, he is comatose and he is having hypotension, bradycardia, oliguria, and tachypnea. How are we going to manage this gentleman? The treatment modalities include charcoal hemoperfusion, resin-based hemoperfusion, hemodialysis, and continuous veno-venous hemodiafiltration, or plus hemoperfusion, hemodialysis plus hemoperfusion. Another case scenario, and here we have a 67-year-old female who is diabetic and hypertensive.
Dr. Kirti,
Sir.
Dr. Kirti,
Sir.
Sorry to disturb you. ఇది ఏంటంటే ఏం టాక్సిసిటీ అన్నట్టు ఇది?
సార్,
ఇప్పుడు పేషెంట్ హైపోటెన్షన్, బ్రాడికార్డియా, ఇంకేముంది
సార్?
ప్రెజెంట్ చేశారు కదా.
హైపోథెటికల్ కేస్ సార్, కేస్ సినారియో అంతే. హైపోథెటికల్ ఫర్ సమ్ పాయిజనింగ్.
హైపోథెటికల్ అయినా సరే
అదే హిస్టరీ చెప్పాలి కదమ్మా. హిస్టరీ ఆఫ్ కన్జ్యూమింగ్ పాయిజన్ ఏదో, లేకపోతే ఫీవరా ఏదో ఉండాలి కదా. హిస్టరీ లేకుండా హైపోథెటికల్ ఉండకూడదు.
తీసుకుందన్నా. He has taken something, but he has symptoms like bradycardia. He has taken some substance, comatose, hypotension, bradycardia, oliguria, tachypnea.
Okay.
ఇక్కడ చాలా మంది రెసిడెంట్స్ ఉన్నారు, అడగండి డిఫరెన్షియల్ డయాగ్నోసిస్.
సరే ఈ ప్రెజెంట్ ఫస్ట్.
Okay, please carry on. Sorry, please carry on.
We have 67-year-old female who is diabetic and hypertensive, presented with fever, who is stuporous, oliguria, jaundice, and in hospital course she was ventilated and has inotropic support for 12 hours. How are we going to manage this lady? Again with charcoal perfusion or resin-based hemoperfusion, hemodialysis only, or continuous veno-venous hemodialysis plus hemoperfusion, or hemodialysis plus hemoperfusion. I am going to discuss in these lines history, physical properties of hemoperfusion, indications, types of therapies and comparison, complications, and summary. Coming to history, it was started in 1972. They used resin filters to filter the urea, and then again in 1972 we have charcoal hemoperfusion. In 1990 we have resin-based hemoperfusion. Coming to hemoperfusion principle used is adsorption. Adsorption is when atoms or molecules or ions diffuse into a bulky volume, whereas adsorption is when the atoms or molecules settle on a surface. Absorption of chemicals. We have activated charcoal and resins. In activated charcoal, drugs are poisons which are irreversibly bound via van der Waals forces. Whereas resins, drugs are not irreversibly bound and can be eluted with organic solvents. Water and lipid soluble substances with molecular weights ranging from 100 to 40,000 Daltons are well absorbed with hemoperfusion. Chemicals at higher molecular weights are absorbed less efficiently to polymer coated resins. Indications for hemoperfusion in case of poisoning: when there is progressive deterioration despite intensive support therapy, severe intoxication with depression of midbrain function, thereby leading to hypoventilation, hypothermia, and hypotension. Development of complications of coma, such as pneumonia or septicemia, or impairment of normal drug excretory function due to hepatic, cardiac, or renal insufficiency, or intoxication with agents such as paraquat. Coming to poisons which are removed by hemoperfusion are paraquat poisoning. In paraquat poisoning, there is a continuous charcoal hemoperfusion that prevents progression to pulmonary fibrosis and improves mortality. And we have, in case of severe organophosphorus poisoning, which is less beneficial in mild overdose. It is indicated in carbamazepine severe massive overdose and in theophylline also. In methotrexate drugs, which can be removed by hemoperfusion are methotrexate, diltiazem, phenytoin, valproate, chloramphenicol, and muscarine. These are the drugs and chemicals that are removed with hemoperfusion, but most commonly removed are ethylene glycol, lithium, salicylate, acetaminophen, ethanol, methanol, metformin, benzodiazepines, cardiac glycosides, calcium channel blockers, valproic acid, beta-adrenergic antagonists, atypical antipsychotics, methadone, oxidone, NSAIDs, tricyclic antidepressants, cocaine, heroin, and isopropanol. Coming to the paraquat poisoning, this was a trial conducted, this was retrospective analysis conducted between 2012 to 2015, and it has enrolled 101 patients, and they are divided into two groups in which only received gastric lavage and other one received the hemoperfusion, and they also compared the early hemoperfusion versus late hemoperfusion, in which they are 62 persons died, but those who received hemoperfusion have improved survival rate. Time dependent hemoperfusion after acute paraquat poisoning. If they are treated within 4 hours of paraquat poisoning, there is a better outcomes when compared to the late, and second treatment should be within 20 hours. Coming to the extracorporeal therapy, where and when to consider the extracorporeal therapy in case of poisonings. The poison should cause serious morbidity and mortality, and the poison should not be removed by an antidote, and they should not be eliminated. There should not be any treatment that eliminates the poison, or the endogenous poison clearance should be less than 4 ml per minute per kg, and the poison volume of distribution should be less than 1 to 2 liters per kg. And again, if all these are present, and again, if the poison is protein bound, and if it is more than 95% protein bound, treatment modality of choice is therapeutic plasma exchange. If it is 80 to 95%, treatment of choice is hemoperfusion. If it is less than 80%, and if there comes the role of molecular weight. If it is 15,000 Daltons, there is role of high flux hemodialysis. If it is 15 to 25,000 Daltons, it is hemodialofiltration. And it is 25 to 50,000, we have high flux membranes, and there is, if it is greater than 50,000 Daltons, therapeutic plasma exchange. Coming to the factors that affect the absorption, affinity of the drug, surface area, adsorptive capacity, and rate of flow, equilibrium rate of the drug from the peripheral tissue into the blood. Coming to the extracorporeal treatment for sepsis, and sepsis is defined as a life-threatening organ dysfunction due to dysregulated host response to infection. A rationale behind the hemoperfusion in case of sepsis. Later, Horn and Madsen suggested the cytokine model, proposed that decreasing cytokine blood concentration would restore an appropriate cytokine gradient between blood and infected tissues, thus promoting leukocyte chemotaxis. This is another one. Ronco et al. Proposed the cytokine peak hypothesis. Blood purification decreases the pro-inflammatory and anti-inflammatory molecules during early sepsis, thus avoiding a toxic threshold to be reduced by hemoperfusion and thus limiting the organ dysfunction. Coming to the high cutoff membranes. High cutoff membranes are characterized by large pore than the standard high flux membrane. Here, the technique here is the convection would maximize the high flux cutoff membrane ability to remove the pro and anti-inflammatory mediators, but the cons includes excessive albumin loss. So the use is not the use is not limited to sepsis, but it can be used also in rhabdomyolysis and multiple myeloma. This was the trial Ivory study conducted in 140 early septic patients with AKI with ultrafiltrate rates of 35 and 70 ml per kg per hour, but didn't show any effect on mortality and the secondary outcomes also, that includes ventilator-free days, renal replacement therapy, and vasopressor-free days. Coming to the adsorption in sepsis, we have polymyxin B immobilized fiber column, cytosop, and HA330 modified.
David, discussion at the end, David sir.
Hello?
Shall I continue, sir?
Yeah. Discussion at the end.
That is better, no?
Okay, sir.
Right.
And we have modified AN69, that is auxiliaries. We have another new one, that is Seraph 100. We will come across later. The available hemofilters are Ashi, which is charcoal, and Gambro, it is also charcoal, and Torre Industries, we have Torimycin and Cytosop, and Jaffran, which is a Chinese company, we have HA130, 230, and 330. Coming to the Toramycin, we have UFAS trial in 2009, where they included 64 intra-abdominal sepsis patients, but they found somewhat decrease in mortality, ICU, and ventilator-free days. But again, in 2015, we have Aptomix trial, which doesn't show any decrease in mortality or any secondary improvement in secondary outcomes. And again, we have Euphrates trial. Polymyxin B is usually limited to endotoxin removal, which is in gram-negative sepsis, and we use endotoxin assay for that. And they included 194 patients with endotoxin assay, which is greater than 0.6 to 0.89, and this also didn't show any 28 days mortality benefit or secondary outcome. Coming to Cytosop, that is polystyrene divinyl benzene copolymer, and which has a biocompatible coating, 300 to 800 microns diameter. Indications are include severe sepsis, septic shock, cardiac surgery with SIRS, and cytokines, chemokines, anaphylotoxins, myoglobins, preglobulins, bilirubin drugs can be removed with Cytosop. Treatment includes 24 hours daily for 2 to 7 days, and blood flow 150 to 700 ml per minute. Anticoagulation, as with any extracorporeal therapy, we have to anticoagulate with heparin or citrate. Cytosop, we have these studies from 2013 to 2007, but we don't have any improvement in mortality, but it significantly reduces the IL-6 levels. Coming to the auxiliaries, we have 3-in-1 cartridge. We have endotoxin adsorption in the upper level, which is negatively charged, and polycation at the middle level, and where we can observe chemokine cytokines, and lastly we have polyacronitril where which is used for hemodialysis. Oxidase has 3 different layers, and it is so it can be used for 4-in-1 device, which can be used for renal support, cytokine removal, endotoxin, and we can, as it has heparin, it is local anticoagulant. Advantages are it combines both the blood purification and kidney support in a single device. As it contains heparin, it may cause heparin allergy, and it absorbs our antibiotics like vancomycin and amikacin. Instructions for use include every 24 hours, but it can be used for up to 72 hours in case of gram-negative septicemia, or it can be used even with gram-positive. It can be used for sepsis with AKI. More beneficial if it is used early in the time course, thus limiting the host immune response. Early application includes within 3 hours of adequate fluid resuscitation of the treatment, and it improved the SOPA score. This is a case series. We don't have any trials. We have only just case series with 60 patients in case of oxidase that have improved with the cardiorenal status and vasopressor requirement. Coming to the Jaffran Hp filters, these are Chinese, and these are styrene divinyl benzene copolymers, and we have 3 varieties, which are HA130, 230, and 330. HA130 is used for chronic dialysis complications. Molecular weights removed are 5 to 30 kilodaltons. And we have 230. This is used in case of intoxications. And HA330, it is used in sepsis. And toxins removed are mild uremic toxins in case of HA130, and hydrophobic or protein-bound exogenous substances in case of HA230, and HA330 we have complement cytokines and hemoglobin removal. HA330 is mainly used in sepsis and septic shock, and it removes the cytokines, complements free hemoglobin, and therapy is for 2 to 6 hours daily for 2 days. Coming to Seraph 100, this one is a new variety. This have non-porous heparin, which is negatively charged, and its advantages, it can be used in early sepsis, and it absorbs wide range of viruses and bacteria. Coming to COVID-19 and hemoperfusion, the device used is HJ100, which is used in patients with severe disease who are on corticosteroids, and they are divided into 2 groups: those who are mechanically ventilated, or who are in severe disease but are not ventilated. Use of hemoperfusion reduces the need for mechanical ventilation, and in those who are mechanically ventilated, there is reduced mortality. Coming to the MARS, the molecular adsorbent recirculate circulation. This is used in acute hepatic failure, wherein the majority of toxins leading to the organ failure are accumulating in blood are bound to albumin. Therefore, the concept of albumin dialysis has come, and it includes the charcoal adsorbent and albumin in dialysate. Coming to the inference, is preferred to hemodialysis for the removal of chemicals that are lipid soluble or are highly protein bound. Hemodialysis is preferred for water soluble low molecular weight compounds, since these compounds readily cross the membranes. In the advent of high flux dialysis membrane, hemodialysis can be used for coming to charcoal hemoperfusion, it removes uric acid, creatinine, middle molecules, and other uremic toxins. The combination of hemodialysis and hemoperfusion takes advantage of both techniques. Coming to the problems, with hemoperfusion, there is platelet depletion, fibrogen depletion, leukopenia, hypotension, and there is excessive removal of calcium, glucose, hormones, coagulation factors, and trace elements. Thank you.
Thank you, Kirti, for simple and nice presentation on hemoperfusion techniques in ICU. Amon sir.
సింపుల్ ఏంటి సార్ ఇది? సింపుల్ కాదు, మాకు కష్టమే.
అంటే తక్కువ టైంలో ఫినిష్ చేసింది.
Jaffran, you start your history and the differential diagnosis.
Sir, the patient came with some toxicity and had taken, I think, bradycardia, unresponsive, and ఇంకా ఏమన్నా hypotension ఉంది కదా
సార్? hypotension, bradycardia,
unresponsiveness. చూడండి ఒకసారి.
First case.
Oliguria and
Oliguria, tachypnea. So hypotension, bradycardia, oliguria, comatose, tachypnea. So దీది ఏమన్నా రెసిడెంట్స్ ఏమన్నా చెప్పగలుగుతారా? ఏం మందులు తీసుకోవచ్చు పేషెంట్?
సార్ ది హైపోటెన్షన్, బ్రాడికార్డియా, కోమటోస్, ఈ మూడు ఉంటే మోస్ట్ ప్రాబబ్లీ ఓపియాయిడ్స్ ఆర్ సెడేటివ్స్, హిప్నోటిక్స్ ఉంటాయి సార్.
డ్రగ్స్ ఏమేమి ఉన్నాయి అంటే ఓపియాయిడ్ పాయిజనింగ్ ఒకటి, ఇంకా సెడేటివ్స్, హిప్నోటిక్స్ అంటే స్పెసిఫిక్ డ్రగ్స్.
ఆల్కహాల్ ఉండొచ్చు, బెంజోడైజెపిన్స్, బార్బిటరేట్స్ ఉంటాయి సార్.
ఇంకా
సార్ బీటా బ్లాకర్స్ సార్, బట్ కోమాటోస్
ఉండొచ్చు. బీటా బ్లాకర్స్ బికాజ్ కోమాటోస్ కెన్ బి బికాజ్ ఆఫ్ ద లో కార్డియాక్ అవుట్పుట్.
కాల్షియం ఛానల్ బ్లాకర్స్ ఆల్సో.
కాల్షియం ఛానల్ బ్లాకర్స్
హై డోసెస్ లో ఈవెన్ బ్రాడికార్డియా కూడా కాజెస్ సార్, బోత్ గ్రూప్స్.
Okay, how will you manage this case? Go through the management protocol.
Hello?
You are directly concentrating on hemoperfusion, but how will you manage the case practically? Raghu.
సార్ ఫస్ట్ ఏబిసి సార్,
అంటే ఇప్పుడు మనం చెప్పిన దాంట్లో సరే ఓకే సారీ మరి చెప్పిన దాంట్లో డయాగ్నోసిస్ లో పర్ఫ్యూషన్ చేసే డ్రగ్స్ ఏమేమి ఉన్నాయి ఇప్పుడు మన టాక్సిసిటీలో డిస్కస్ చేసినాం?
ఏమ్మా అంటే చూడకుండా చెప్పు, చూడాలేంటి
సార్? ఇథిలిన్ గ్లైకాల్, మిథనాల్, సాలిసిలేట్, అసెటమినోఫెన్, మెట్ఫార్మిన్, బెంజోడైజెపిన్స్, కాల్షియం ఛానల్ బ్లాకర్స్.
ఇప్పుడు మనం డిస్కస్ చేసినవి ఏం డిస్కస్ చేసాము? ఓపీ పాజిటివ్ డిస్కస్ చేసాము, బీటా బ్లాకర్, కాల్షియం ఛానల్ బ్లాకర్,
బెంజోడైజెపిన్స్,
బార్బిటరేట్స్, ఓపియాయిడ్స్. సో దీంట్లో ఇంకా ఉన్నాయా డిఫరెన్షియల్ డయాగ్నోసిస్?
సెప్సిస్
కొంచెం టకికార్డియా ఉంటది, ఓకే, బ్రాడికార్డియా ఉంది ఈడ. ఇంకా సో ఈ ఒకసారి లిస్ట్ చదవండి అమ్మా, మీ లిస్ట్ చదవండి ఏమేమి ఉన్నాయో.
ఇథిలిన్ గ్లైకాల్, లిథియం, సాలిసిలేట్, అసెటమినోఫెన్.
ఇథిలిన్ గ్లైకాల్ ఇట్లా ఉంటుందా
సార్?
ఇథిలిన్ గ్లైకాల్ ప్రెజెంటేషన్ ఏముంటది?
ప్రెజెంటేషన్ ఇథిలిన్ గ్లైకాల్ ఉంటుందా
సార్? హై అనియన్ గ్యాప్ మెటబాలిక్ యాసిడోసిస్ ఉంటుంది సార్.
ఓకే.
సో బ్రాడికార్డియా, హైపోటెన్షన్ ఎక్స్ట్రీమ్ కేసెస్, బ్రాడికార్డియా అన్యూజువల్ సార్.
ఇంకా సాలిసైలేట్స్ ఉంటది, సాలిసైలేట్స్
కూడా రెస్పిరేటరీ ఆల్కలోసిస్ ఉంటుంది సార్. ఇథనాల్, మిథనాల్ కూడా బ్రాడికార్డియా, హైపోటెన్షన్ రావచ్చు సార్.
ఇథనాల్ కూడా ఉంటుంది దీంట్లోనే ప్రెజెంటేషన్. సో నౌ ఇప్పుడు మనం డిస్కస్ చేసిన దాంట్లో డయాలైజబుల్ టాక్సిన్స్ ఏమున్నాయి?
అనదర్ వన్ ఇస్ అది కార్డియాక్ గ్లైకోసైడ్ సార్, డిజాక్సిన్, డిజిటాక్సిన్.
డిజాక్సిన్ ఉంటది,
అవి కూడా బ్రాడీ, హైపోటెన్షన్ అండ్ డయాలైసిస్.
డిజాక్సిన్. సో ఇప్పుడు డిజాక్సిన్ ఒకటి డయాలైజబుల్, ఇంకా తర్వాత బార్బిచురేట్స్ అన్నాం కదా, బార్బిచురేట్స్ ఉన్నది, ఇథిలిన్ గ్లైకాల్ ఉంది. లిస్ట్ చదవండి అమ్మా ఒకసారి.
సార్ ethylene glycol, lithium salicylate,
lithium salicylate, acetaminophen, ethanol, methanol, metformin,
benzodiazepines, cardiac glycosides, calcium channel blockers, valproic acid, beta adrenergic antagonists, atypical antipsychotics, methadone, oxycodone, NSAIDs, tricyclic antidepressants, cocaine, heroin, and isopropanol.
Mohan sir, ఇప్పుడు ఏమొచ్చిందంటే half of the drugs mentioned can be removed by normal hemodialysis also. That doesn't need a hemoperfusion itself.
Yes, agreed.
Ethanol, methanol can be easily removed by hemodialysis. So these అంటే larger molecules ఉండవు కాబట్టి may not need a hemoperfusion.
But if you don't know the drug exactly, that dialysis only is not sufficient enough to remove all these explained drugs. No? So we have to use hemoperfusion if you doesn't know the drug unless you get the report.
కానీ ఒక డిఫరెన్షియల్ డయాగ్నోసిస్ అనుకుంటాం కదా సార్, based on the presentation.
అనుకుంటాం. Majority of the drugs can be dialyzed with dialysis, removed.
Yes.
But some specific drugs, if it can't be unless you know.
No, as Dr. M. Srinivas is telling, what is the difference if you do the heme absorption? The normal hemodialysis is going to be different with these drugs. Am I right, Srinivas?
Yes, sir. Yes, sir.
Yeah.
Kirti, can you differentiate which drugs can be removed with dialysis and which can't be removed with hemoperfusion?
Sir, depending on molecular weight, sir. Which are above 15,000,
that we don't know unless you measure all these things.
We know the molecular weight.
Common drugs which can be dialyzed with the normal dialysis can be removed, but without hemoperfusion.
Yeah, Kirti, you mentioned in another slide.
Yes, sir.
Theophylline, carbamazine. Just load that slide.
These are the drugs which can be removed by hemoperfusion, sir. Methotrexate, diltiazem, phentoin, valproate, chloramphenicol, and muscarine.
It can't be done by routine dialysis, no?
Routine dialysis.
Kirti, can we use high flux dialysis or high cutoff membranes for this rather going for a hemoperfusion?
High cutoff membranes, and they are mostly used for sepsis, sir. And case studies are there only for sepsis, and they are not.
Because it is dependent on the molecular weight you are saying.
Right.
So obviously, when you use a high flux membrane, you will get a high molecular weight molecule.
Yes, sir.
So is there any difference that we can see? ఏమైనా ఉందా డిఫరెన్స్, అడ్వాంటేజ్ ఏమైనా ఉందా
దేంతో సార్? విత్
హీమోపర్ఫ్యూజన్ తో అడ్వాంటేజ్ ఏమైనా ఉందా?
No sir, if they can be removed with hemodialysis, it is better to go for hemodialysis only rather for hemoperfusion.
సిచ్యువేషన్ ఏంటంటే ఇట్స్ an unknown poison కదా.
We can based on presentation we can somewhat know what can be the poison we can.
See, when you don't know and your differential diagnosis includes some drugs which are removed only by the absorptive technology, the molecular weight or high cutoff doesn't give any advantage, right? If you are going for an absorptive technology, the removal will be higher with a shorter time. If you are going with a high cutoff, your removal will be slower as compared to hemoperfusion. Okay, so ante okasari unknown poisoning vachi you are suspecting some kind of like methotrexate or e type of where you are absorptive technology లేకుండా remove చేయలేవు అనుకో, then you go better for a hemoperfusion. And your differential diagnosis doesn't have these things, then better go for a high cutoff. So mostly 70 to 80% can be covered with high cutoff. Kind of ఒకవేళ absorptive technology definitely use చేయాల్సిన drugs, patient already on a methotrexate, patient already on dilzium, all these things, you suspect those poisonings.
Yes, sir.
Okay, అలాంటప్పుడు you better go for a hemoperfusion.
Hemoperfusion. Okay, sir.
Now, one more point, Srinivas, as Dr. You are telling, Kirti is telling, and David is talking about, everybody is talking about sepsis. So, do you really accept the cases? Do you really feel there is a benefit in the sepsis?
Sepsis is a very gross term, sir. A sepsis, a condition. It depends.
No, any sepsis, do you think that the heme absorption is going to benefit?
Depends which filter are you using. Is it for an antibiotic filter or only an interleukin removal filter? Okay, if you are going for a torimixin, okay, even though the trials doesn't show, okay, one thing what we have to understand is Euphrates trial, when they have done the study, they have seen a benefit for patients between EA value of 0.6 and 0.8 or 0.9. So more than what she has given is a overall benefit for a EA value more than 0.9 also. But the benefit after the trial, after the post hoc analysis, what they have given is around 0.6 to 0.8 or 0.9. Within these range, they had a better outcome. And secondly, your outcomes will be better when you are using in a specific time. So patient already in dual vasopressors, so you will not be able to do any much. So patient already has deteriorated, you will not be able to do much. So it should be in a very initial stage, but how much initial, that we don't know exactly. That patient said they have taken in Euphrates, have used torimixin filter with a NORAD support of 0.05 mics. So NORAD of 5 to 6 ml they have taken into consideration. So for that, in that case scenario, half of our ICU patients should go into this. And they have done in patients only in abdominal sepsis or post-abdominal surgery landing up in sepsis. So if you can take the correct patient at the correct time and the correct criteria, you may have benefit. If regarding to cytosorb or auxiliaries, maybe it's a personal opinion, institutional practice, and there is nothing proven. Sir,
especially this Euphrates torimixin is used basically, has shown whatever the number of studies, it has consistently shown a benefit in a patient's early use in intra-abdominal sepsis. But other sepsis, it did not give much differences, whether a mortality or morbidity. And cytosorb also did not show much because it removes some cytokines, interleukins, but the outcomes, overall the outcomes, there's no much difference, and that's the reason why sepsis, surviving sepsis guidelines has said that no outcome differences. They have clearly this time has given a recommendation also.
How many cases we have used in sepsis in Visakhapatnam or in Hyderabad?
Sir,
for the sepsis.
For sepsis, I think I have used 4 or 5 filters, specifically torimixin, and Hyderabad, Dr. Rajupal has used a maximum number of cytosorb filters in India.
Okay, let us not talk about them. At least for your side, Srinivas, out of the 4 cases, what you used? What is your experience?
My experience, sir, out of that, I think 2 patients were on ECMO. It's a desperate attempt, but 2 patients survived.
Okay.
And the other 2 patients were in septic shock, and that too, I think 1 patient survived. So that ultimately, when we do in the larger numbers, we will know actually the better we will have. If we have an experience, then we will know much better. In desperate situations only it is done.
No,
So, but as
my gut
Sir,
feeling,
Mohan sir, నేను
as
చెప్తాను.
Dr. Srinivas has mentioned,
మౌనంగా
if you put a criteria and do it, like a patient who is on XML of noradrenaline on ventilator, or you use an endotoxin assay and you do it, you may show, but evidence is not supporting it.
Sir,
I know
Mohan,
as చెప్పండి.
yeah,
సార్ ఇప్పుడు సార్
yes, Srinivas, carry.
Sir, ఏం లేదు. So I have put around 60 to 80 cytosop filters. Okay, so it is obviously the timing and the patient set only has mattered. Okay, if it has been put in a right time, they had showed some significant improvement. They came off vasopressors, oxygen requirement has decreased. But in cases where it was put in a desperate situations or in a random situation, they didn't have much benefit. Toromyxin, definitely 0.6 to 0.8. Definitely, if you go for a set of patients, then yes, yeah, there are 70% chances the patient may come out.
Is there any RCT for this, Monanga?
RCT, sir. RCT.
Euphorus trial, sir.
Yeah, but
Euphorus is RCT. Euphorus and RCTs.
We discussed, no? Do you have any idea?
Yeah.
All the trials?
గుర్తుంది last time discuss చేశారు. I remember that.
That is all personal experience or case reports that early is the best 70% what Srinivas is telling. But all the studies shows there may be increase in the hemodynamic improvement or decrease the ICU length of stay, but not the mortality.
Sir, అదే సార్ ఇప్పుడు ఏంటంటే ఇప్పుడు మీరు యూఫరెట్స్ ట్రయల్ తీసుకుంటే దే హావ్ టేకెన్ ఆల్ ద పేషెంట్స్ ఫర్ ఈఏ వాల్యూ మోర్ దెన్ 0.6 అంటే పేషెంట్ ఈఏ వాల్యూ 1 ఉన్నా సరే వాళ్ళు తీసుకున్నారు. సో ఇన్ దోస్ కేసెస్ ద పేషెంట్ ఈస్ ఆల్రెడీ అంటే చాలా సిక్ గా ఉన్నాడు. సో
what is the subset, what is the subgroup
subgroup తీసుకున్నది ఈఏ లో పోస్ట్, కాకపోతే ఇట్ ఇస్ అ పోస్ట్ ట్రయల్ పోస్ట్ హాక్ అనాలిసిస్ కింద తీసింది. ఇట్స్ 0.6 to 0.8. వాటిలో డెఫినెట్ గా మోర్టాలిటీ బెనిఫిట్ ఉంది. బట్ ఇట్ ఈస్ అ పోస్ట్ హాక్. ఆబ్వియస్లీ ముందు చేసే సబ్ కేటగరైజేషన్స్ కన్నా అది స్టాండర్డ్ అని చెప్పము. బట్ వాట్ ఎవర్ ద ఎవిడెన్స్ వీ హ్యావ్ 0.6 to 0.8 హ్యాస్ అ గుడ్ మోర్టాలిటీ బెనిఫిట్.
Sir, actually that Euphorus trial actually eye opener for the researchers. Actually, still there we don't have an evidence base that is which it using the hemofilters improves the mortality, but morbidity what David and Srinivas is telling is certainly the organ improvement and inotrope requirement is much better shown in Euphorus trial. Based on that, actually so many new filters came, as Kirti mentioned. The Jaffran company HA, they have upgraded their filters 130, 230, now latest one 330, and Oxaris and other one Saphira one. These things though it's not case studies only, maybe we have to wait some more days to get results. Other thing is, as Srinivas tell, this is the if you use in a desperate situations, it's not useful, sir. Certainly after resuscitation, after antibiotic proper coverage, that is the right time. If a patient is not improving, we can try. But thing is we are getting actually new versions of filters which much better than that older one, that is Toramycin, sir. That's all, sir.
Yeah, actually,
finally everything boils to the finance.
Yeah.
అంటే ఫైనాన్సెస్ వచ్చినప్పటికి ఏంటంటే ఆబ్వియస్లీ ఇట్ ఈస్ లైక్ 1.5 lakh or 1.6 lakh with a machine and all those things. So you are giving a 2 lakhs extra bill to the patient in our city with our logistics and settings. How much it is reasonable and rational, that we have to decide on the bedside.
Yes, 4 lakhs adding for a patient.
I think the latest filters are much cheaper, I think.
Yes.
Much
sir,
cheaper.
yes.
filters
I think what the Mohan Rao sir is mentioning is, I think 40,000 and thousand, sir. They are having a different molecular weight at different forms, like liver and kidney and filters as well. I think that is అది అవసరం అనుకుంటే మనం యూజ్ చేయగలిగితే కనుక we can use in a good number of patients. All ఒక ప్రోటోకాల్ తయారు చేసేసి మనం యూజ్ చేసుకోవచ్చు కూడా కంపెనీతో మాట్లాడి. Because the number of centers are high, no మనకి.
సార్ అది శ్రీనివాస్ సార్ మీరు చెప్తున్న 40,000 దట్ ఈస్ ఫర్ ఇంటర్లూకిన్ రిమూవల్ ఓన్లీ ఐ థింక్ కదా, సైటోసాబ్ కి వర్షన్స్ బట్ నాట్ ఫర్ టారోమిక్సిన్.
టారోమైసిన్ కాదు, టారోమైసిన్
సైటోసాబ్.
సో అది నాకు కరెక్ట్ గా కూడా ఐడియా లేదు. ఆ ఫిల్టర్స్ ఒకసారి వచ్చారు వాళ్ళు. సో ఐ థింక్
yes sir, we have also used it.
That specific filters are there which are coming in a very low cost when compared with these 40,000-50,000. I think we can use that in larger numbers so that we can get a good data.
ప్రాబ్లం ఏమంటే సార్ వాళ్ళ మెషిన్ స్పెసిఫిసిటీస్ కూడా వేరేగా ఉన్నాయి. ఎందుకంటే we have used 3 అంటే 30,000 వే ఎలా ఉన్నాయని చెప్పేసి ఒక 3 వాడాము. సో he needs a machine specific అంటే వేరే మెషిన్ ఇచ్చి వాడించాడు వాడు.
మనం అందరం కలిపి 10 హాస్పిటల్స్ ఆర్ దేర్, మనం కొన్ని వాడతామంటే వాడు మెషిన్స్ కూడా ఇస్తాడు కదా.
అదే అంటాను, మెషిన్స్ కూడా వాడిచ్చినవే వాడాలి. ఇట్స్ నాట్ లైక్ అంటే ఆక్సిలరీస్ ఉందనుకోండి, యూ కెన్ యూజ్ ఇన్ ద సిఆర్టీ మెషిన్, టోరోమిక్సిన్ కానీ ఇది కానీ సైటోసాబ్ కానీ సిఆర్టీ మెషిన్ లో వాడేయచ్చు.
సో అట్లా మాట్లాడితే కనుక ఐ థింక్ మీకు తెలిస్తే ఒకసారి మోహన్ సార్ కి చెప్తే కనుక he can talk with the company person and we all can use. Cost is not very high. We can get a nice robust data also. Company can get.
అలా కాదు, మెయిన్ ఇంపార్టెంట్ ఇష్యూ ఏంటంటే ఇక్కడ ద టైమింగ్ అండ్ ద ఎర్లీ ఇనిషియేషన్, దట్ ఈస్ వేర్ వి గెట్ ఇన్ టు ట్రబుల్ అండ్ వి విల్ నాట్ బి ఏబుల్ టు డిసైడ్. దట్ ఈస్ ద క్వశ్చన్.
సార్ ఇంకోటి ఏంటంటే ఈవెన్ ద టైమింగ్ ఆల్సో వెదర్ ఆక్సారిస్ కానీ సైటోసాప్ కానీ టోరోమైసిన్ కానీ did not show the outcomes. That's a thing he has from the evidence base.
Actually no studies and no control studies or RCTs will give more of the mortality benefit because the number needed to treat will be very high. The issue is that even any patients getting benefit or buying a time or giving a duration of time to improve the cause by acting on original cause, like sepsis is going with the antibiotics. So if that is giving a time to maintain till that time, the patient survives. So indirectly it is improving the mortality even though they don't show into the result of any mortality. So that's the reason that anytime when they talk about mortality benefit, when they talk about any studies, they don't want to commit themselves because it's going to be tough to prove. But when they talk about morbidity, and it's like what we are in ICU, like how important is each component, like you call it as nutrition or infection control policies or everything. The same way this toromycin and this very costly treatment, whatever you call it as, compared to the logistics, as Monanga told, whether it's going to, if we are going to give the time or buy the time for the patient duration of stay in ICU without deterioration itself is going to improve the mortality. So the issue here is that, as you said, we have to differentiate understanding the filters for what we are using. And it only starts at the time of in ER, whether these people are going to be, because by the time any one of our hospital will not get a stable patients or early, it is going to be little delayed. That is the main problem for us, because we won't get, we get only shocky patients and who are not ready for dialysis, only for hemoperfusion or CRRT. Those kind of patients, and the 24/7, because most of the times when we receive the patients in the evening or nights where we are not available. We are available only on the phone. So seeing the patient at that point of time, deciding it, counseling it, communicating it, getting it done with the logistics of with the pharmacy, all these people, it's a very Herculean and good and really, really encouraging and inspiring thing. But how really we are going to do that is a matter. But anyway, as you said rightly, this specific, not only the timing and the cases, what we have to deal with, the number of cases we get has to be done in future. It will be really, really good. But we can really do the better work by all of us.
Sir, you said the randomized control trial will give the correct evidence of whether it is working or not. What is the problem with doing randomized trial in this usage of this one, toromycin or something? Better, sir.
What you need is the number, sir. It's not
okay. What is the problem with number? Sepsis cases are millions of cases are there in the world.
Sir, abdominal sepsis. Abdominal sepsis. The cause.
Abdominal sepsis also. If you take only abdominal sepsis, number is not the issue to use it.
Sir, Euphorate trial. Each patient has received 3 to 5 toromycin filters.
How many number they have? How many cases they treated?
సార్ వాళ్ళది 194 200 అనుకుంటా.
Ah.
సో అందులోని సో వాట్ దే యూజ్డ్ ఇస్ 3 to 5 filters per patient.
Yeah.
Okay, it is not possible in our settings. Meeru it is like
study
8 lakhs.
I think they can do if it is not possible in our settings. అంటే వెస్టర్న్ కంట్రీస్ లో పాసిబిలిటీ ఇష్యూ కాదు కదా.
When it comes to anything, sir, I still have I may be wrong. Please excuse me, I may be wrong. Because most of the times when I have seen Zigris, we have used Zigris with so much cost and we know what is going to be. It's a company driven things most of the time. So including these kind of things, we have to keep fingers crossed and decide anything when we talk of it. Because we always
half an hour పడుతుంది.
Sir? Sorry?
వేరే డిస్కషన్ అనుకుంటా. ఓకే సార్. సార్ వాట్ ఇస్ యువర్ ఎక్స్పీరియన్స్ ఇన్ పాయిజనింగ్ ఆర్గనోఫాస్ఫరస్?
మీరు ఎవరిని అడిగారు సార్, మళ్ళీ చెప్పండి.
అంటే మీకే డూ యూ హ్యావ్ ఎనీ ఎక్స్పీరియన్స్ ఇన్ యూజింగ్ పాయిజనింగ్?
Routine poisoning, sir.
Most probably organophosphorus poisoning, which is most common in our country.
Okay. ఇది ఉపయోగపడుతుందా సార్?
అంటే ఎవరికైనా ఎక్స్పీరియన్స్ ఉందా మీకు అవర్ టీమ్ లో?
Does it need a filter, sir?
Hello.
Does it need a filter?
ఎందుకు ఫిల్టర్ కావాలి మీకు ఆర్గనోఫాస్ఫరస్ పాయిజనింగ్ కి?
Hello.
Yeah, it will remove the poison if it comes early. So if you use early, within 6 hours, poisoning can be removed and the outcome will be better.
Hello.
రాని మేడం
సార్ అది ఇప్పుడు మీకు ఆల్రెడీ యాంటీడోట్ స్పెసిఫిక్ యాంటీడోట్ ఉండేటప్పుడు యు ఆర్ గోయింగ్ ఫర్ అ హైయర్ కాస్ట్ ఎక్స్పెన్సివ్ థింగ్ కదా.
No, అది 40,000 ఎంత ఉంది.
వెరీ చీప్.
Yeah, that's what.
రాని మేడం చెప్తున్నారు వినండి.
మేడం చెప్పండి మేడం.
Hello.
చెప్పండి మేడం.
Yeah, David Mohan sir, Srinivas was saying about the sepsis, but about the poisoning cases, like when we know something is definitely dialysable, it's easy to convince the relatives about the dialysis and initiate quite early. But in sepsis cases, it's not easy to convince them for hemoperfusion or cytosorb or auxiliaries, anything, because it's so expensive also. And early means how early is early? That's the question. And by the time we get the patients here, they're already on like they need dual vasopressors, high doses, and treated outside. All these cases, even if we start perfusion or whatever, like expensive RRTs, they may not make any difference in the mortality. So that's one thing. And regarding poisoning, I think we used in supravasomal poisoning, we started immediately from Delvin people. We got the filters and we have done, and almost all supravasomal poisoning, we saved the patients. Like they recovered very well with the filters. Can't remember. Are they charcoal filters, Srinivas, from Delvin?
High cutoff filters, ma'am. HA330.
Yeah, we have used them. As soon as we get the patients in ER, we call them and we got those filters and initiated. And almost all of them in last few years, last 3 years, we remember everybody is saved, and they think supravasomal, they are definitely going to die, but none of them died in our setup here. And all these dialysable drugs, whatever are dialysable, like a dialyze very early, and we can save them. But OP poisoning, I don't think we have done, unless they have gone into secondary infection sepsis. So then maybe we have done, but not to start with.
OP poison going into secondary infection sepsis. What is the use of doing this, madam?
I'm saying just for removing the poison, we didn't do.
Sepsis ki, Anna, sepsis ki.
Sepsis ki that is different issue. For organophosphorus poisoning, there is one study from I think Chennai or somewhere. They have done so many cases in a national conference. One person presented almost the recovery will be fast when compared to treating the patient within our protocol without using these filters. The recovery will be early by removing the poisoning. This intermediate syndrome.
దాంట్లో ఇంటర్మీడియట్ సిండ్రోమ్ లేదని చెప్పినట్టున్నాడు.
Intermediate syndrome is because you are removing the poison within 6 hours. A patient will be recovered early. That is the main benefit. Maybe 99% patient may improve without using these filters, but takes time, prolonged ICU stay or tracheostomy, all these things. But if you use these filters, the paper study shows that
కానీ సింగిల్ ఫిల్టర్ తో అవ్వదేమో సార్.
సింగిల్
ఎందుకంటే సింగిల్ అవ్వదు.
Not single. They have to
exactly.
do
So obviously, when it comes to poisons, so the main drawback or complication is the rebound increase in the poison level from the tissue, adipose tissues.
Not single.
So that needs repeated filters.
So that one is there. One complete only organophosphorus poisoning. This thing. They have paper presentation in national conference. That's why.
Kirti, one question. Hello.
Sir, చెప్పండి.
అదే మార్స్ కి ప్రోమిథియస్ కి ఏమైనా can you give some knowledge about Mars and Prometheus?
No sir.
Okay.
నువ్వు చెప్పు మౌనంగా.
Sir, it is mainly charcoal and albumin based dialysis for the removal of toxins that has to be removed by the liver. So it is a dual circuit mechanism. Okay, single circuit ఉండదు, it's a dual circuit mechanism. CRRT plus another circuit that has to be attached with this. Whatever the studies till now didn't show any benefit because first thing is the financial. Mars circuit costs around 2 lakhs and Prometheus is around 2.5 or 3 lakhs, and the circuit runs only for 24 hours. Edadi there is single oka difference. Mars lo primary circuit lo it is albumin permeability లేని సర్క్యూట్. అంటే 2 ఫిల్టర్స్ ఉంటాయి, ఒకటి హై ఫ్లక్స్, రెండోది ఏంటంటే ఆల్బుమిన్ పర్ఫ్యూజన్ పర్మబిలిటీ లేని ఫిల్టర్. ప్రోమిథియస్ కి వస్తే యూ హ్యావ్ హై ఫ్లక్స్ అండ్ ఆల్బుమిన్ పర్మియబుల్ ఫిల్టర్, అండ్ ఆఫ్టర్ దట్ ఇట్ విల్ గో టు ద అదర్ సర్క్యూట్. సో ఇట్ రన్స్ ఫర్ అరౌండ్ 24 hours, బట్ obviously the timing, initiation, that definitely matters, but when it comes to the expense, no one is ready to put it.
This Mohan sir, if you remember, we have done this in 2002 in NIMS, Mars. So
నేను అంతకు ముందు ఆ తర్వాత ఢిల్లీలో మన మేదాంతలో కూడా చూశాను. అక్కడ మార్స్ నేను చూశాను.
అక్కడ ఏంటంటే సార్ అంటే సర్క్యూట్ స్టార్ట్ చేసే లోపు పుణ్యకాలం అయిపోద్ది అంటారు కదా, సో ఆ టైప్ అనమాట. ఇట్స్ లైక్ వెన్ యూ స్టార్ట్ ఇట్ ఈస్ అరౌండ్ 100 steps టు స్టార్ట్ అండ్ ఇట్ టేక్స్ అరౌండ్ 3 to 3.5 hours టు ప్రైమ్ ద సర్క్యూట్.
But specifically it is done in liver failure patients. So but outcomes లో పెద్ద మేజర్ డిఫరెన్స్ ఏం లేదు కదా. ఇది
mainly if your center is for LTs, so for buying time, patient is not responding with any of your plasmapheresis or CVV HD, so a patient may go for, the patient is like financially sound and he may go afford the circuit. So initially without any wasting time, when the patient comes, start with the
it's a bridging
కోసం వాడాలి. It's not for the outcomes. It's
they
for
were
the
much using in Gangaram at the time. We attended the workshop as well. Long
bridging kosame vaadaru. Some patients will deteriorate in spite of whatever therapy, and ante liver ready ayalope ALF patients deteriorate ayipotaru. So in those cases it might be helpful.
But now it's not working, no?
Yes, sir. Expenses is too much that nobody is ready to put. You can't convince.
Okay. Any more questions? What is your experience in dengue shock syndrome, Srinivas?
In which one, sir?
Dengue shock syndrome.
Dengue lo cytosab. Cytosab use cheyalesi, sir.
One important question to everybody. Hello, can I ask? Yeah, Srinivas, David, and M. Srinivas and Rani, madam. See, normally, sometimes we are not supposed to get a malaria patient who is dying because of parasite load. Is there any value of these filters in a parasite load reduction?
I think
I
understood. Parasite load reduction in case of malaria.
Malaria with multi-organ dysfunction, is there any benefit by using these filters to reduce the parasitic load?
I think plasma paresis should be done for reducing the parasitic load.
లేదు సార్ అసలు ఏమి రోల్ అయితే లేదు because WHO clearly said that first don't check the parasitic load. If the parasitic load is, if you check also high also, there is no role of plasma paresis or exchange, because the artesunate have a very high killing capacity and faster, so that there is no role of other adjuvant therapies.
Okay, but we have used in Chennai when I was doing that IDCCM.
Yes, మన ఏజ్ కూడా అయింది కదా సార్, చాలా సంవత్సరాల కింద చేసినాం.
చాలా సంవత్సరాలు.
కానీ డేవిడ్ సార్ అపోలో చెన్నై అసలు ఎవిడెన్స్ లేకుండా ప్లాస్మా పెరిసిస్ స్టార్ట్ చేయరా?
అప్పుడు those in 2010 they did a plasma paresis, one patient having high parasitic load.
అందుకే అడిగాను నేను.
అంటే వాళ్ళ అంటే చెన్నై అపోలో అసలు చేయరు కదా ఎవిడెన్స్ లేకుండా.
అవును, they might have some evidence for that. Now that the guidelines have changed.
Sir, Mohan sir, can I?
Yeah, please.
Yeah, in CMC Vellore, actually, when I'm doing that time itself, WHO not recommended that this exchange transfusion, but still the CMC people does this exchange transfusion when the parasitic load is more than 10. So idea and means they theoretically think once the parasitic load if you decrease, then this artesunate works more effectively and we can reduce the resistance to the artesunate also. So maybe I did few cases actually.
Yeah, Mohan Rao, maybe because of the anecdotal experience, I still feel the same. Because when the parasitic load is more, when parasitic load is less, just like how you are taking care of IL-6 reduction, the same working more better efficiency or improving mobility is by using the plasma paresis is really better with high malarial parasite load is my feeling. I don't know, I may be wrong or right. Just correct me.
There may not be evidence for that, but majority still they are doing this plasma paresis if load is very high. What about resistance, sir? You are telling artesunate resistance. I don't think artesunate resistance there in India till now.
చచ్చిపోయాడు సార్ మలేరియాతో, అందుకని నాకు బాధ అంతా. రీసెంట్ గా we lost one patient with
multi-organ failure and shock.
అదే కానివ్వండి, బట్ బై ద టైమ్ హీ రీచ్డ్ హియర్ ఇట్ వాస్ డిలేడ్ renal failure and all. That's okay, but is dying people with the malaria is really pathetic. My question is, he has been gone to the doctor and he said please come back tomorrow, we will investigate, and he did not come. After 1 week he came with multi-organ dysfunction.
Adi
and as
plasma paresis appudu edan role unda? Is there any role of doing plasma paresis?
I don't know, because the patient is already so sick and they did not affordable, but I was interested in doing that. And the recently one patient, do you remember Dr. Mohan Rao from Kottavals nunchi vachadu? Mohan Rao, anyway,
bed number 2 Satish.
Yeah, so that's why I really feel that how much useful of this, because they come late or whatever you call it as. So
thing is, and that means actually patient came in altered sensorium. He was admitted under neurophysician. They are evaluating. When we found that platelets low, we send all the thrombocytopenia fever workup. Initially, the malaria came negative. Second day, it came positive. So that is why the treatment also got delayed, sir. So patient we succumbed, sir.
So as Jackina is telling, there is no use of looking at the parasitic count. I am just discussing this point. By time is over, David, but still, this is the reason we discuss.
అంటే ఇప్పుడు లేటెస్ట్ WHO guidelines not required to do parasitic load because artesunate will remove almost more than 90% of parasites.
If you really do in early, yeah.
Main thing is WHO
But
is
India,
not concentrating on our coastal belts, sir. What is Srikakulam areas?
actually gana Indialo artesunate resistance is not there, but it is there in Bangladesh and all African countries.
So these people are not reporting, sir. These people are not reporting. Suppose if you are giving artesunate 3-4 days, still parasitic load is there, MPV is still positive is coming, then certainly it means resistance is there in our area. That is why then sometimes we have to use the twin also physicians along with artesunate. So these our DMHO people are not reporting at our hospitals.
Right, sir. The time is over. Shall we close this?
Yeah, please. Thank you, Kirti.
Thank you, Kirti and Mohan sir, for moderating. Thank you all.
Anybody is telling something?
Madam.
Hello. Can I suggest one thing to juniors when they present with hypothetical case? Can you please do like a proper case scenario and approach to the case, how you are starting your management and why you are ending with your opinion about starting
Conclusion.
like perfusion or whatever you want to say. Approach, how you approach, that's how I think you should practice for your exam purpose also.
No, that's how we have to prepare the hypothetical case.
Yeah, that's how you should prepare the hypothetical case. It should fit into your diagnosis, the criteria, what you're talking about, the signs and symptoms or approach, and then what initial management, then how do you get to the particular specific management. If you do like that, it will be useful for everybody also, for all the students.
I think your student Shintu and Tripti is in the class, ma'am.
Sorry?
Dr. Sinju and Tripti were in the class?
Yeah, they are in the class. All like Mahesh, Shankar, everybody is here.
Very nice. Okay.
Thank you.
Thank you, madam, for suggestion. Thank you all for your active participation. Thank you, Kirti.
Thank you.
Log out చేయమ్మా.